and welcome to this episode of ConCensis, a podcast brought to you by ConCensis Technologies. I'm your host, Michelle Dawn Mooney, and today we're speaking with Brian Dawson of CommonSpirit Health. Brian, it's great to have you here today. Can you start us off with a brief introduction and talk a little bit about your role at CommonSpirit?
So, Brian Dawson, I spent 28 years in the Navy as a Navy officer, nurse, OR nurse, hospital executive, and then system executive. I was a hospital COO and then CEO. And in my last 2 years, I was the chief of staff and EA to the Navy Surgeon General. With CommonSpirit, I started about 5 years ago working for Dignity Health as their system leader for perioperative services. And when we merged with CHI, my job expanded for all of our facilities. So I'm kind of the leader, but more so the director of perioperative things.
And tell us more about the facilities and teams that you work with.
So OR-wise, we've got 142 operating rooms across the system. And so they range in size from 2 ORs that are being utilized to 60 ORs that are being utilized. We have critical access hospitals. We have community-based hospitals. And then we have about 5 very large teaching hospitals. And so the cool part about CommonSpirit as a faith-based health system is we run the gamut, from inner city hospitals that are the only hospital in that inner city. Long Beach is an example, downtown LA is an example, Glendale, along with some of our other facilities, to the only hospital in a rural area. So we have critical access hospitals. We've got hospitals that have 2 OR rooms, and they're in literally a farm community. So the coolest part about us is we serve that population, and we might be the only provider in that population. So, our SPDs run the gamut from, like I said, from staff that run the OR that also support SPD to facilities like St. Joe's. We kind of run the gamut in size, which makes us unique and kind of a fun challenge. How do you come up with a solution like ConCensis that can help us in all of those types of facilities?
So what are some of the challenges that you face in your day-to-day interactions with all those facilities?
I really think it's just because it's me and I have a great partner in crime. One of the individuals who works for me, Charlene Rutella, is not an administrative assistant. She's truly like my right hand. We have a great perioperative council, which is made up of OR leaders from every division. And if a division crosses state lines, from every state in that division. And then we have a larger group, a perioperative collaborative group, which we invite members from every OR, whether they be the director, whether they be an educator, the business manager. We have subcommittees. One very important subcommittee is our SPD subcommittee, which is, again, made up of SPD leaders from across the system. We've got an educator group, a policy group.
Well, it sounds like you've got a good group of people there helping you manage everything. So what part of your role do you enjoy the most? What's the most impactful to you?
Helping, teaching, solving the big riddles, the big puzzles, and being that steward of our dollar. Because, again, healthcare is getting tight. You hear in local media, national media, there's talks that are, people are worried about taking place soon within Congress about cutting Medicare, Medicaid. That used to be the golden check that every hospital got from the government. And now, you're not getting that type of reimbursement. A lot of hospitals were impacted due to COVID, but because of a lot of the legislation, the federal government was giving facilities and health systems dollars to offset the cost of COVID. Well, now that that's stopped, and now that we have, COVID, serious flu, the new respiratory illness that's impacting children a lot, those things are all impacting on areas in our hospital where we generally lose money. And what I mean by that is the longer a patient stays in the hospital, the less insurance covers. So for me, what's important is how do we increase the use of our operating rooms, which means how do we make sure that instrumentation for surgery is made readily available? How do we do that in the most cost-efficient manner possible? And how do we make sure that the quality and patient satisfaction is top-notch? Because that's what draws people to a facility, not just the patient, but that draws the providers, our surgeons, to a facility where they know they're going to have what they need when they need it. And the quality that's provided by the staff, by the nursing staff, by the assistant staff, by anesthesia is going to be top notch. So their patients are going to have a very positive outcome.
Brian, I think you touched on this a little in what you just talked about. So let's dive a little deeper in terms of providing the optimal outcomes. Can you kind of walk us through how you measure productivity in your facilities?
Yeah. So let's talk about SPD specifically. The best hospitals measure OR productivity through minutes of service. How many minutes is the patient in the OR? What I love about ConCensis is we've worked together to utilize AMI. AMI is the Association for SPD, and they set SPD standards. AMI has come out with levels of complexity. So they've listed tasks, whether it's putting together an instrument set or whether it's pulling for a case or putting peel packs together or cleaning a robotic arm. They've set time frames for all of those tasks and grouped them between level 1 and level 4. Level 1 meaning about 20 minutes, level 4 an hour and a half to 2 hours. And so we've worked very closely with ConCensis to create a way of monitoring all of the tasks that are done in an SPD, and then bouncing that off of those 4 levels of complexity. And now we can tell how many staff do I need to take care of the workload that happens in SPD, and how many staff do I need throughout the day based on workload. I need less bodies in the morning because there's nothing coming out to be cleaned and processed, and more bodies in the afternoon because that's when the bulk of the work comes out. So for me, that's one of the 4 holy grails in the OR that I've been trying to solve.
When we talk about productivity, we have to take staffing into consideration. Have you had any challenges finding and maybe more importantly, retaining qualified staff in your SPDs at any of your facilities?
Yes. And major issues finding staff. And that's because it's very hard to find qualified SPD technologists and retain them. One, there aren't a lot of schools that train them in doing so. And then the other problem is the salary range for those individuals fluctuates nationally, and in some areas it's at a level similar to our housekeeping and dietary staff, which, I get it, it's an entry-level position, but the level of complexity that we now have within that department, you almost need a bachelor's degree to how to follow the national guidelines on decontaminating and sterilizing or high-level disinfecting different items. And SPD handles items from surgical instrumentation to laparoscopic instruments to robotic instruments to endoscopy scopes. It's across the gamut. And, those individuals have to know how to care for all of that appropriately and according to manufacturers' recommended guidelines and national standards. And we're paying them, at a level that's kind of entry. And so the turnover is fairly significant.
And tell me, how does that turnover affect your productivity?
Yeah, it does, because then the problem is I've got individuals that are that haven't been trained, and it takes me longer to do things because I'm constantly retraining staff.
When you're dealing with network-wide productivity, do you ever have issues with limited visibility into your processes?
Not really. Like I said, because we have such a great group, especially in SPD. The SPD leaders, I think, are the tightest of all the leaders. And so there's a lot of conversation, sharing of information. There's a lot of creation of standard processes, standard checklists, standard, education, competencies. So we're doing a fairly good job at ensuring that we're all at the same level, all following the same things. Now, having a standardized tool like ConCensis makes it even better.
So have you used ConCensis in your facilities during your entire tenure, or is it a recent addition?
We've been using the tool, I would say, for about anywhere between 9 to 12 months, regularly. But we just started working with the leadership at ConCensis to create the productivity measure that I was describing in the past 4 or 5 months. I'd say 3 to 4 months. And now my hope is that we can deploy that across the system.
In terms of network-wide productivity, do you have any other bottlenecks or maybe efficiency issues with your SPDs?
Most healthcare executives don't really understand what SPD does. And I say that not because, they're not smart or they're lacking education. SPD is usually in the basement of the hospital. And so, as you said, when there's greater turnover, when we don't measure productivity by what it is they do and use minutes of service, then we're cutting staffing in SPD because they're not productive, which results in I don't have enough time to thoroughly clean all of the instruments, and people start to take shortcuts. And then it becomes a major issue, and you're on the cover of the newspaper, and there's a lawsuit, and there's millions of dollars that are spent. Well, to prevent that, let's spend a couple of $100,000 and increase the salary and measure productivity the right way in SPD. It's this, what came first, the chicken or the egg? And so one of the reasons why, for me, educating people on this is important is because I've been an OR leader where SPD falls underneath my purview. And I've also been a hospital executive and a system executive. And I would always say to, leaders, hey, we got to focus on the backbone of the department that serves the area where we generate our revenue. Come down, visit SPD, see what they're doing.
Let's dig into that productivity module that you've been working with. What are your thoughts on interactive data platforms?
I think that if we are able to work with a manufacturer to capture that data, and that we know that the data is pristine, and the data uses national benchmark measures, then I think it's priceless.
Do you have any advice to give to other hospitals or networks that are looking for a tool to measure their productivity?
I would say, find something. Find something that works so that you can have the data to make intelligent business decisions, to support your procedural areas, business decisions in SPD, to support your procedural areas to make sure that you can capitalize on the assets you have to generate revenue.
So let's talk about looking into the future. What are your long-range goals for tracking productivity?
Yeah, I think the goal would be to, across our system, have a hub and spoke type data sharing network, for lack of a better term, where, as I just described, I could potentially move staff and move equipment to the need within that division. And when I use the word division, I'm really talking about geographically located facilities. Let's go to Sacramento. There are 5 hospitals in Sacramento in a circle, right? So if you ride the highway that goes around Sacramento, we've got 5 hospitals in that vicinity. All 5 of those hospitals are part of the same group, so why not look at where the need is, when the need is, and move assets and people based on that need? Another crazy idea is, what if we created a centralized SPD amongst those 5 hospitals, and we moved instruments to that area to clean, decontaminate, sterilize, and then move them back to where they were needed? And now I've got a centralized hub where I can take advantage of that staffing and that equipment for 5 separate hospitals. And even a better possibility is to make sure, what do I see in the future? To make sure that our leaders understand the value of that department and the value of using data to make business decisions, to increase efficiencies, to save dollars, and to utilize the most precious asset we have to its fullest extent, and that's personnel.
A great conversation, Brian. I want to thank you so much for joining us today, and thank all of you for tuning in and listening today on the ConCensis podcast, brought to you by Censis Technologies. Once again, I'm your host, Michelle Dawn Mooney. Thank you again for joining us. We hope to connect with you soon.